Most of the time when I'm speaking, and I speak a lot, I think I did 17 conferences last year. Most of the time when I'm speaking, I'm representing somebody, whether that be the Katie or some different organizations that I work with. But today this talk is entirely mine. So my views and opinions here are my own. They don't represent either my employer or any other organization. So I'm not wearing my Katie name tag today. Another really important disclaimer here is that I am not a lawyer. I am going to talk a little about your State Practice Act a little bit later in this talk. And I'm going to give you on its face interpretations by somebody reading it, not things that I've talked to your licensure board about. So with that said, maybe the most important thing I can say is thank you. This is a meeting that is near and dear to my heart. I've been here 12 times now. And it's always a pleasure to come down here and talk to you. It's been fun to watch this meeting grow over the years and become really a really excellent meeting. So I have 3 goals for my talk today. The first is to introduce you to some concepts you may or may not be familiar with. One of those is the Institute of Medicine's core competencies for healthcare providers. Another is the IHI Triple Aim for Healthcare. Anybody heard of the Triple Aim before? Not a lot of you, a couple of you. So that'll be actually pretty helpful. It's a very big picture talk. This is not a 10,000-foot talk. This is a 100,000-foot talk. It's going to fit pretty well in Domain 5 if you're keeping BOC score at home. So it's really about administration and advancement of the profession. We're also going to talk about some legal underpinnings for determining standards of care that you provide as an athletic trainer. And eventually, we're going to get around to talking about areas where you may be self-limiting your practice and thinking in a way that actually restricts what you're doing as an athletic trainer. So let's play a game. This is called Athletic Trainers Can't. Some of us have been around long enough where this is a pretty extensive list. But athletic trainers can't are things that you have been told or taught about what you can't do as an athletic trainer. So I'll throw out the first one. Athletic trainers can't diagnose. How many of you have heard that one before? Yeah, a bunch of you have got a bunch of hands, particularly those of you who are starting to get a little gray like me. What are some other ones? Just throw them out. Anybody? Sutures. Athletic trainers can't suture. What else? Hand out medicines. How about dislocations? You heard athletic trainers can't do dislocations? Can't reduce dislocations? How about give injections? Do anything invasive? I got a bunch of these that I put together that I've heard over the years. Diagnose, reduce dislocations, give injections. Those are some of the low-hanging fruit. Give any medications. I've been told that before. Do dry needling. Athletic trainers can't do that. Put in sutures. I've even been told we can't take out sutures. That one's a little silly to me. Apply a cast or remove a cast. I've been told that. Apply custom or apply or customize durable medical equipment. Treat non-athletes. You hear that one fairly often. Treat non-sports injuries. Make return-to-play decisions. Bill insurance for care. These are all things that we often say to each other. And here's the problem. Nearly all of these are false. It's going to depend on a few factors, and in some states, some are more false than others, and we'll talk about your state here specifically a little at the end. But here's another fun piece. Every single one of these is legal in multiple states. Just depends a little bit about where you live. So let's get into this talk and understand a little bit about what is scope of practice and where does it come from. So what is our scope of practice as athletic trainers, and what should it be? And what you're going to find is that more often than not, what we think of as our scope of practice is actually much narrower than how it's legally defined. So where do we fit in the community of healthcare providers? A big piece of understanding our scope of practice is understanding how you fit in the bigger picture. Do we even know? So I'm going to recycle a couple of slides that I've used in a few talks over the last 2 years because I think they help me make a point. First, how many of you have heard that we're not supposed to use physician extender as a practice setting? Okay, well, not as many hands as I'd like to see. Let me reiterate this for you. We're not supposed to use physician extender as a practice setting. And the reason for that is because every athletic trainer in every healthcare setting is an extender of the services provided by the physician that we work with. So if you are a secondary school athletic trainer, you are a physician extender. If you are an outpatient rehab athletic trainer, you are a physician extender. If you're in athletics, if you're in an ortho clinic or a neuro clinic or a peds clinic or a hospital setting or a rehab setting or an industrial setting, you are a physician extender. That's what we do. Standard 1 of the POC Standards of Practice says that we work under the direction or in collaboration with a physician, which means all the care that we do is an extension of the authority of that physician. That's why we don't call working in a physician's office a physician extender. We all do it. Here's the question, though. Do we teach our new athletic trainers, or even our old athletic trainers, how to do this? Do we give them all the skills and the things that they need to do this job well? So here's some things to think about. How many of you have seen the blood test for concussion? I'm not going to debate its merits, but we are looking at an era where we may see a blood test to confirm whether or not a patient has a concussion. Here's my question for you. If something like this becomes an everyday reality, if this test becomes a good test and an accessible test, how would it change your practice? What would you need to be able to do? Draw blood. Here's a question. This is not an if, this is a when question. We're going to have more and more blood-based tests and other laboratory-based tests that we use in athletic medicine. That's an area we're just starting to see the biomarkers thing go on, but it's coming, and it will be mainstream practice in a very short window of time. So with that said, if you aren't trained to draw blood, who is going to do this for your patients? Now, if you're like me and you're at a major Division I athletics institution, we have a physician in every athletic training facility every day. So I can get somebody on the doc's list. We could maybe have the doc do this when they come in. I have to tell you, though, we've got 1,100 student athletes. And my physicians do not want to sit there and be doing blood draws on all of these patients when they got a whole line of people to see. That's not a primary physician skill. That's something they delegate to other healthcare professions. So if you can't do this, and you have to send your patient somewhere else, if your doc can't commit to it, here's a question. How much more time is that going to take from your patient? How much more money will that cost them? And how much more inconvenience will that bring? Because if I can't do it, and my physician's not going to do it when he's in because he's got too many people, I got to send him to student health. I got to send him to LabCorp down the road. I have to send them somewhere to get this test done. I just made it more costly, less convenient, and harder for them to get access to that care. Would that be a barrier to your patients receiving appropriate care? You have patients who are non-compliant now and doing the things you want them to do? Absolutely. What if you have a patient who's self-pay? You know, do I really need to get this other thing done? It's probably going to be a barrier to their care. Here's another thing to think about. I really like this slide because it is from Akron Children's Hospital in my hometown of Akron, Ohio. And this is a job advertisement for a suture technician. Hospitals are training suture technicians. If you go to Akron Children's Hospital, or almost any significant hospital you're going to find these days, the physicians aren't sewing people up in the ER. They're having technicians do that. The physician comes in, looks at it, makes sure the tendon's not cut, everything is okay, and they send somebody else in to sew you up. That person's a tech, not a physician assistant, not a nurse. It's usually a tech. And to become a suture tech, I went through this job ad, you had to have a high school diploma, or GED, that'll count. You had to have non-degree healthcare experience. So that could be something like a medical assistant, which you don't have to get a degree to be. You had to have a CPR card. This is not an advanced medical procedure if we're teaching it to non-degree people with a GED and a CPR card. Yet, if you could perform this skill, and I'm not saying discretionary use of wound closure, but when your physician says, yeah, go ahead and close that up, if you could close that up, could you save your patient time, and could you save your patient money from having to send them off for something else? The answer is probably so. Giving an injection is a basic healthcare skill. It is performed by many different professions and owned by none. It's done by medical assistants, again, non-degree people, as well as everybody up and down the healthcare chain. This is also a basic healthcare skill performed by many professions and owned by none. That is, basic phlebotomy and administering of IV medications. No one has ownership of these particular skills. They're skills in healthcare that are used to meet a patient's need. Here's another one to think about. I like this one. If you can't see this picture really well, this is an athletic training class learning to put on and take off casts. How many of you have paid money out of your own pocket to pick up an additional credential so you could do your job? Something like an OTA, those kinds of things. A few here and there. We're seeing more and more of this. Well, I want you to go get this other certification so you can do casting. The question is, why should we have to pay additional money on top of our education to do our everyday job? The question is, why don't we teach that as part of our education to do our everyday job? So did you notice athletic trainers were the ones doing and performing all of these things? Many professional AT education programs, that is, programs that lead to eligibility for the BOC exam, are already teaching all of these skills. And every professional AT program will be teaching them by 2020. 2020 is when the new standards go into effect, and every single one of those things I just showed you is in the new educational standards for athletic trainers. The reason it's there is that our patients and our physician partners benefit when we can provide this basic healthcare skills that they need without having to add an extra step and an extra expense in the healthcare cost and experience of that patient. Which brings us to the big picture. The changing world of healthcare delivery, and how do we fit into it? So let's talk about the professional degree. In 2015, the Strategic Alliance organizations got together and talked about this topic after lengthy debate and comment, and made the decision to move us to master's entry for all athletic trainers to sit for BOC eligibility. If you are curious, when does that actually happen? It's kind of a rolling date. The fall of 2022 is the final time an undergraduate athletic training program can enroll a new cohort of students. But what that means is that that group has to go through their program and graduate. So we'll probably continue to have undergrad programs till 2025 or 2026 for the last few that we'll finish out. Many programs have already made the move to the master's. Moving there is not simply repackaging what we've always taught in athletic training education. It has to be something more, and we have to provide graduate-level education to afford a graduate-level degree. Degree change is a means. It is not an end. The goal was not to change our degree. The goal was to change our education. The degree was an important piece of that. But the goal is to change our education to better equip us to provide the services that our patients and our supervising physicians need. Some of the rationales that were in the white paper were things like increasing complexity of the healthcare system, a growing need for AT outcomes, which we desperately need, expanding scope of knowledge and skills to do your everyday job, and need to ensure alignment with other healthcare professions. When you look at these rationales, the big four rationales that were in that degree change white paper, 1, 3, and 4 all have to do with fitting into healthcare and expanding the knowledge and scope to meet the needs that we have in that role. So those are the major driving factors to why we've made a change. So we are healthcare providers. How many of you use that in your elevator speech? I'm a healthcare provider, I'm a medical professional. Okay, a few, I'd like to see a few more. This is the definition from the Profile of Athletic Trainers in the NATA website. So this is sort of your official definition of what an athletic trainer is. I'll be honest with you, I think it's missing a few things. We'll get to those in a little bit. But it starts out with that we are healthcare professionals. And if we're going to be a healthcare professional, we need to understand what that means, how we fit in the big picture, and what impact that has on the way we approach our job. So, athletic trainers are healthcare professionals. What does that really mean? It means we need to adopt a healthcare professional's mindset. And that means we have to embrace the culture of healthcare. And to be honest with you, that's a radical change of mindset for a lot of us. In my generation, and even in today's generation, many athletic trainers see themselves as the athletics staff person who does the healthcare. That is, your culture and your identity is wrapped up around the athletics. And you have a role in athletics as the healthcare provider. What we have to do to fit into the bigger picture of healthcare is to flip that. Your culture and your identity has to be in being a healthcare provider who happens to have this role with this particular group of patients. Healthcare provider first, athletics second. Or as I had somebody explain to me at one talk, it can't be about the logo on your shirt. It has to be about the patient on your table. It's a flip. But once you make this flip, some things start to fall in place for you conceptually. Things like, why should I not be the person doing the laundry and handing out the equipment? Why should I not be handing out the soap or handing out the meal tickets on the bus trip? Why does my role with my patients look different than the other healthcare providers, even in my school system? Do they ask the school nurse to do those same things? Does the school nurse also have to be a teacher to have their job? Again, when healthcare is your secondary identity, it changes the way that you practice compared to if you make it your primary identity. It's not an overnight change, but it is a gradual change that has to happen as we go forward. So to do that, to understand the mindset, let's go 100,000 foot and talk about what healthcare is all about. This is something called the IHI Triple Aim. The Triple Aim is about population health, experience of care, and per capita cost. And if you have not heard about it before, this is the number one thing in healthcare worldwide. It was first described in 2007, and we have to understand and embrace its goals. If you want to learn more about this, I have a link down at the bottom. It's ihi.org. But the Triple Aim is about this. First, it is about population health. In almost all of the literature now, people are talking about themselves as health professionals, not health care professionals. A health professional does not only care when people are ill, but they also work to prevent them from being there in the first place. Does that sound like your job? Sounds like my job. But it's a bigger picture look. In population health, our job is to improve health, not just to provide care. It's about disease prevention. It's about better access and better systems of care. It's about social determinants of health. If you're not familiar with social determinants of health, there's been a lot of good papers in the last few years on this. But a great example of this is in Boston, Massachusetts. There are 2 zip codes that are geographically 5 miles apart at their center. And those 2 zip codes have a 35-year difference in life expectancy. 5 miles apart. And a big piece of that is access to care, quality of care, and culture of seeking care. Those are things that we can affect. Do you work with students who are under-resourced or impoverished, and what impact has that had on their ability to seek and receive care? What it means is you find ways to get it done because the system sometimes fails them. All of that things go into population health. The experience of care is about patient-centeredness. Patient-centeredness means my patient's needs and desires and wants and expectations are central in their care. It's not do it this way because I tell you to. It's do it this way because it helps us achieve the goal that is important to you. So looking at the patient's individual goal. I'll give you a great example. My wife has the biggest needle phobia of anyone you've ever met. If she has to have a blood draw, she's going to scare people in the parking lot. When we adopted a couple of our children from Russia, we had to have blood tests as part of that process, and they actually had to gas anesthetize her to be able to get a blood draw. So when she broke her foot 5 years ago, she had a nice stiff neck fracture, displaced. Every physician she saw wanted to put a pin in it. The idea of cutting her foot open was not great to my wife. We finally found one who was willing to treat her conservatively, put her in a boot, and let her ride a scooter for 6 months. And that was preferable to her than having a pin put in and being non-weight-bearing for a couple of weeks. Patient-centeredness meant that physician was willing to look at her needs and wants and find a care solution that met them, even if it wasn't the standard care solution. That's a patient-centered approach to care. Patient-centered approaches also take in things like cultural competence. And we know that that's a really big factor. In my city, we have a large Somali immigrant population. It would be completely inappropriate in their culture for me to examine a female patient one-on-one. I would have to have a male relative in the room to do that. And I can say, well, that's a really sexist thing on their culture and they need to change. Or I could meet the patient's needs. Because if I don't meet the patient's needs, they're not even going to come in to seek care. So that's a little bit of patient-centeredness. Per capita cost is obvious. The healthcare costs in the United States are unsustainable in our current model. We spend more per capita on healthcare than almost any other third world nation, and our outcomes are lower than most of them. The system has to find a way to reduce costs while still providing quality care. This is what healthcare is all about. And as a healthcare provider, understand, how do you impact this? What things do you do to improve access to care? In many cases, you may be the primary access to care for the patients you work with and their families. Anybody ever take care of a patient's family member on the side? Almost all of us have at some point or another. You help contain costs because you don't have a big budget to work with. You're trying to find a way to meet the need for the lowest price. We're great at that. An experience of care, who's more patient-centered than we are? Who does the patient come to interpret what the doc just told them? That'd be you. Athletic trainers not only work within the context of that triple aim, even though we haven't talked about it before, but we also do primary care. How many of you use primary care in your elevator speech? I say, what I am. I'm a healthcare provider, and I do primary care. I'm not seeing any hands. You should. We absolutely should, because if you understood the definition of primary care, you're going to say, that looks just like my job. So what does it mean, and how do we fit in? My favorite primary care definition comes from American Academy of Family Practice, the AAFP. So you can Google AAFP primary care, and you'll find this definition. I love it. I've added a little emphasis, but let's go through it. It's care provided by physicians. It's a physician organization. Comprehensive first contact and continuing care. That means I'm the first person they see, and my care with them continues forward. Does that sound like what you do in a traditional setting? I treat whatever just walked in the athletic training room. I'm often the first person to see it. The undifferentiated patient, not limited by problem origin, biological, social, behavioral, organ. Do I work with people with eating disorders and orthopedic problems and diabetes and cancer and all kinds of things? That's us. This is absolutely us. Then you look at this bottom piece, and this bottom piece here is kind of important. Primary care includes health promotion, disease prevention, health maintenance, counseling, patient ed, diagnosis and treatment of acute and chronic illnesses in a variety of settings. Is that your job description? You should all be nodding your head yes. That is exactly the job description of the typical athletic trainer. Yes, we have a few specialty setting practices that may look a little different, but the standard run-of-the-mill athletic trainer is that bottom paragraph. You are primary care. If we go to the next half of this, primary care is performed by and managed by the physician, often collaborating with other healthcare professionals. What did BOC Standard 1 say? Athletic trainers work under the direction and in collaboration with a supervising physician. We are one of those other healthcare professions. You should be using primary care to talk about yourself. Things like patient advocacy in the healthcare system, cost-effective care, coordinating services. Are you the hub of the wheel coordinating services for your patients? In many cases, you absolutely are. Encourages the role of the patient as a partner in their health care. Everything that we do is rote primary care, but it's language we've never used to describe our profession, and I think that's a shortcoming that we've had. I'd love to see us rectify it, and you can be part of that solution. Add primary care to your elevator speech. Why should I do that? The answer, of course, is that people understand primary care. When you talk to another healthcare professional and you say, I serve in a primary care role with this patient group, they absolutely understand what your job is now. When you talk about, I'm an athletic trainer, they have no idea what your job description is. And I've seen that over and over as I talk with my healthcare peers and I explain what I do in primary care terms, they instantly grasp the role and scope of what I do. There's a significant shortage of primary care providers, not just in the U.S., but globally, and that shortage is getting worse. Non-physician providers are going to help physicians deliver care to more and more patients. The way U.S. healthcare is changing, whether you liked Obamacare or hated Obamacare, is irrelevant. But the way it is changing is we're moving away from a fee-for-service model and toward a managed care model. The speed of that will change with who's in office, but the direction of that probably isn't going to change. As you look at managed care, it's about having a physician at the top of the pyramid and a lot of partner providers working with them to meet patients' needs. You are equipped and in the role to be an important piece of that equation if you're wise enough to position yourself for it. This is really the skill sets we have always done, but the question is, do we teach all the pieces of it that would let us do it effectively and on a large scale? And once we grasp those things, I think you're going to see a lot of job markets change for athletic trainers. We need to provide high-quality, affordable care. We need the skills that patients need, and we have to deliver them in a cost-effective way. So, if we are healthcare professionals, and what does that mean? Let's look at it again on the big scale. The National Academy of Medicine is a national think tank. It's part of the National Academies of Science, Medicine, and Engineering in D.C. And the National Academy of Medicine has a number of small think tank groups within it that they call global forums. They have global forums on a number of topics. One of their global forums is on innovation in health professions education. It's the global forum on IPE, basically. The global forum on IPE has the accreditors and the professional associations and the educational associations from virtually every healthcare profession in the United States. And until 2015, that was Accept Us. We were able to join that organization in 2015. But this organization makes policy statements that ultimately impact things like accreditation standards, licensure, and regulation. One of the most important of those came out in 2003, and it's called Health Professions Education: A Bridge to Quality. And it identified the things that every healthcare provider in the world should be equipped to do in their job. So it's not U.S.-centric, it's not profession-centric, it is every healthcare provider in the world. And it was in response to problems in the healthcare system, like errors and poor quality, needs of the chronically ill being ignored, disease prevention and social determinants of health not being factored in. Informatics has taken off in a great way. Shared decision-making, workforce shortages, and gaps between what we're teaching and what you need to do your job. All of those problems went into these recommendations, and there are 5 of them, and these are the 5. All health professionals should be educated to deliver patient-centered care. That's the first core principle. The second one, as members of an interdisciplinary team, that is, we no longer do single provider care, we're all part of a team providing care to a patient. Every member on the team has a role and skills that they bring to the equation. Emphasizing evidence-based practice. Have you heard of evidence-based practice? You're chuckling. There's a reason that it's been such a big focus. The next piece here is quality improvement. We have not adequately addressed quality improvement in athletic training healthcare. It is a big topic in everybody else in healthcare. The literature is rapidly growing, and when you go to look at the AT quality improvement literature, you get crickets. There's almost nothing there about how to improve the quality that we do and improve things like patient safety. And the last piece is the use of informatics. Again, my soapbox about informatics for a moment. You need to learn how to use the electronic medical record. It may not have worked its way into your setting yet. It will. Electronic medical record is not athletic training specific software packages that let us track the things we've always looked at. It's the whole big, real medical record that everyone in healthcare is using. Can I pull up my patient's imaging on the computer in my healthcare facility, even though it was taken across town? Can I get access to their whole previous medical records? What all care providers are they working with? All of that stuff is now part of your patient care decision. It will be coming to a setting near you in the next decade. It's already there in quite a few. Why does the National Academy of Medicine call for that interprofessional education piece? They have another paper on that about examining outcomes of interprofessional education. And here's their statement. It is about improving the health of individuals, responsiveness of the healthcare system, and affordability of healthcare. Does that sound like something we just talked about? That's the triple aim again. All of this is focused on the triple aim. So, what are we doing in athletic training about this? You are probably familiar with the changing education standards for athletic training. The Katie released the final draft of these. That's not a draft, the final approved document of these in March, and they go into effect in 2020. So we have new standards about our education programs, including new curricular standards. I am not going to go standard by standard, but I do want to point out a couple of them. First, there are 4 sections to the new standards. Section 4 is about the curricular content. General things about these standards is that they are a little less prescriptive for a lot of things, but they really focus hard on what we are teaching, and specifically, they focus on things like those core competencies. We've actually added a couple of additional ones that have come out of other groups as well. But, a lot of those things I've just mentioned, we've added professionalism as a competency as well. Things about patient and client care and developing a care plan. Patients do not come to athletic trainers for treatments. They come to athletic trainers for care. And care is not me giving you a treatment today. It's me having a plan of care that takes you from injury or illness and ends at return to play and has everything in the middle. It has to be intentional and focused on the patient's individual needs. There's a lot of things on prevention and healthcare administration, but here's a statement I really, really like. The professional program content will prepare the graduate to do these things. Our old standards always talked about what you had to know and the skills you had to be able to perform. This is really about the outcomes that we need to do with your patients. So let me show you a few examples. Standard 69 here is develop a plan of care. Get rid of that one. Plan of care for each patient. That is a comprehensive, across the spectrum plan. And there's some things that go into that that are pretty important. 72 here is pretty good as well. The graduate will be able to perform or obtain necessary appropriate diagnostic and laboratory tests. Does that mean we need to teach you how to go do a complete blood count? No. Does that mean we need to teach you how to get the sample that gets sent to the lab to get you the complete blood count? Yes. We absolutely need to equip you to either do the test or obtain the sample that gets the test result your patients are going to need going forward in the next era of healthcare. Other things that are in there, I like 70. This is the acute conditions standard. It says evaluate and manage patients with acute conditions, including triaging life-threatening. And then it goes with this laundry list. And there's some things in the laundry list that are important for you to recognize. Internal and external hemorrhages, including use of a tourniquet. Fractures, and by the way, you think an athletic trainer never uses a tourniquet? Boston Marathon bombing. Athletic trainers were using tourniquets and saving people's lives when they had limbs blown off. I know quite a few of those folks, and it made a difference on saving patients' lives that day. Let's see. Fractures and dislocations, including reduction of dislocations. Why would an athletic trainer need to reduce a dislocation? Do you know what the literature says? Early on-field reduction of dislocation has the best patient outcome, and it's not close. If you're not trained to be able to put those things back on the field, you delay care and negate the advantage of early reduction and actually worsen the outcome for your patient if you're not trained to do this on site. Other things that are in here, diabetes, including not just measuring blood sugar, but administering glucagon and insulin. Does that mean I'm the provider you're coming to and we're going to determine your insulin plan? No. Does that mean in a crisis that I can administer insulin to you to save your life or administer glucagon to save your life? Absolutely. Drug overdoses, including administration of things like naloxone. In Ohio, we like being number one, except on this issue where we are number one. Ohio is number one in per capita opioid overdose deaths. As a primary provider out in the field, you need to be able to manage this. It's probably not going to be your athlete in the locker room, but it might be a kid behind your stands or somebody else in your community behind your stands. Wound care, including care and closure. That closure would include suturing if your State Practice Act permits it. Some other standards that are in here. Standard 71 is, again, perform an exam, do a diagnosis and a care plan. Yes, athletic trainers diagnose. By the way, this is not a new addition. Diagnosis has been in our standards for a couple of rounds now. But one of the things that fits into here is comorbidities in patient with complex medical problems. You have a role in that complex patient. Do you have a diabetic patient who also has hypertension and a musculoskeletal injury? All the time. So we need to make sure we're approaching complex medical issues and complex patients. The drug standards. We've always, I shouldn't say always, but the last several rounds of standards have had standards in them that are about things like educating patients. Because let's face it, the doc puts this patient on this medication, and the patient looks at you and says, when am I supposed to take it, and what do I do? How do I get this? How do I use my inhaler? How do I use my EpiPen? We've always sort of had that role. But the second piece here, standard 75, is an important one. Administer medications or other therapeutic agents by the appropriate route of administration. Athletic trainers don't give injections. BS. Athletic trainers do give injections. You should be trained to do it right. Injections are unethical. Well, injecting someone to allow them to play when it's not medically indicated would be unethical. But it's not the injection that's the problem. It's making someone play who should not be playing. That's the unethical piece. Whether you use an injection or not is a function of the medication involved. Some drugs have to be administered by medication. Others can be administered topically. Others can be administered orally. It's completely a function of the pharmacokinetics and pharmacodynamics of that specific drug. If my doc says, let's give this patient this drug, you need to be able to administer that drug. Now, does this say that you should be making discretionary choices about what drugs your patient should have? This is not a prescribing standard. This is an administration standard. How is that determination made of who needs what meds? That's by someone with prescribing authority like your physician. But your physician should not have to give somebody an allergy injection. That's a significant waste of their time and effort to come over to your facility and give your team allergy shots. You should, or flu shots for that matter. If they say, let's go ahead and give everybody on the team a flu shot, and they have prescribed that medication for them, there's no reason in the world you should not be trained to administer that. That's a low-level healthcare skill. 75 here is select, fabricate, and customize medical devices, including durable medical equipment. There was a big issue with that with CMS and Medicare, Medicaid over the last couple of years about whether or not you as an athletic trainer could do that. Are you any good at bracing? Maybe you've heard of this once or twice. You're actually really good at bracing. But under the CMS standards, they weren't going to allow you to do that and bill for those services because you weren't on the list. We absolutely need to be doing that. Another one that's here about interventions, treatments that you can do. Joint mobilization and manipulation is specifically called out in the 2020 standards. There's very good literature to support its effectiveness, and it's something we need to be training our people to do. It's not rocket science, but it's something that has never been a standard piece of our education before. So the educational standards are changing. When you look at why, and what's behind them and what's in them, it's all about equipping you for that primary care role you've always had to be able to provide the services in a cost-effective way that your patients need and that your physicians need you to be able to do. If you can't do them, your docs will hire somebody else in their practice who can. And eventually, those other professions have a big target on your job in athletics because they think they can do it better than you because they have skill sets that we have not always taught. So that's sort of the genesis of where those discussions have come from. So barriers to incorporating. Are we allowed to do this? Legally, can we do these things? So let's go back to our athletic trainers can't list again. All of the things that are on here really boil down to something called scope of practice. What is your scope of practice and how is it determined? So let's take a look at that. First, scope of practice describes what a provider can do. It's what you're permitted to do, and it is it's keeping with the terms of their professional license. So one of the first principles in scope of practice is regulation. Regulation determines scope, but that's not the only piece that does. The scope of practice is limited to what the laws allow, and you see that it is specific to your education and experience and competency. So you need to say, I was taught this, I'm competent at doing this, and the law permits me to do this. That is what your scope of practice is. Every jurisdiction has its own individual laws, so your scope of practice may change from one jurisdiction to another. For example, in my state, we have a very broad and robust Athletic Training Practice Act that allows me to practice on patients in any healthcare setting. Other states have restrictive practice acts that specifically say I can only care for an athlete, or I can only care for an athletic injury. So there are differences in our state practice acts. So when you look at the regulation piece and some of those determinants, this is the most recent regulatory map, and you see that this comes from NATA, and all the states who are in green have licensure for athletic trainers, including your state and my state. South Carolina still has certification. There are a handful of states, I think 5, who have registration, which means I'm certified, I register, and therefore I'm allowed to practice. And the state of California is still working on it. They are getting close, God bless them. Hopefully Jerry Brown won't veto it again. We'll see. But when you look at the things that fit into this, first, your educational standards and competencies, which are determined by the CATIE. That's that CATIE standard list. Your national certification, BOC, state regulation with your state laws and rules, and also facility credentialing. Anybody have facility credentialing? You may not be familiar with that concept. Well, you are, but you may not have thought about it in AT terms. Just because someone is licensed to practice medicine does not mean the Ohio State University Medical Center is going to let you walk in and do surgery. They're going to credential you in their facility to say that our facility says you are qualified and will let you do this. Some places even credential down to the procedure level. They may credential you to perform this kind of surgery, but not that kind of surgery. Credentialing is something that's starting to happen in the athletic training world as well. For example, at Boston University, their athletic trainers are under the student health system, not at the athletics department, and they are credentialed. So if you have gone to a dry needling course and you have demonstrated you've had education and competency in dry needling, they credential you to be able to perform dry needling in their facility. So their facility has examined your training and competence and said, yes, you can do this here. So a lot of healthcare facilities and healthcare networks do credentialing within their facilities. Related concepts to this are some things from our brethren at the Board of Certification. And if you are not familiar with the BOC Standards of Professional Practice, go read them. They're very, very helpful, and they're the big picture ideas about what you should do for legal and ethical practice. And standard number 1 in the BOC Standards of Professional Practice is the athletic trainer renders services or treatment under the direction of or in collaboration with a physician. So nothing we are talking about in the new CATIE standards, or that I'm talking about in this talk today, are intended as discretionary use. Everything you do as an athletic trainer is under the direction or in collaboration with your physician. Some of you collaborate more closely than others. There's a big question about if I agree to go cover some one-off soccer tournament someplace and there's not a physician involved, am I legally able to do that? Well, you better look at your State Practice Act. And if it says that you need direction or collaboration or supervision of a physician, then you better make sure that that's in place for that so that you are legally covered. But this also is in accordance with your training and the state statutes, rules, and regulations. So we work under or with, depending on what your state says, with the physician, and the things that you do are governed by your education and your regulation. This is all scope of practice stuff again. Another related thing comes from Code 3 of the Code of Professional Responsibility, which also comes from BOC. And it says that we practice in accordance with applicable laws and regulation. Again, scope of practice. 3.5, we don't represent in any manner things about our skills, training, credentials, identity, any of those things. That is, we have to be truthful with people and not represent ourselves as able to do something we are not trained to do. And 3.51 says only do the services that you are permitted and prepared to do and that you legally can. So all these things are relevant to scope of practice. Scope of practice, again, was regulation, education, and competence. So when I look at that, let's take a look at your law. So disclaimers again. I am not a part of your state regulatory board, nor have I spoken to your regulatory board about any specific determinations or guidance they've given. This is one outside guy's look at what your law's language says. So we look at the scope of practice within a particular state, like the state of Texas. It's governed regulatorily, typically by 2 things. One is the law, and second is the administrative rules. The law establishes the scope, and the rules provide some description relative to that to help you understand its boundaries. So that's a little primer on the way that works. So in your law, you define athletic training. This is the law, not the rules. And it says, and I've added a little emphasis here, the form of health care includes practicing a bunch of those things we've already talked about. For athletic injuries, that is specifically spelled out in your State Practice Act, and under the direction of a physician. It says direction, not collaboration in your state, which means my physician is the boss, not necessarily my partner, although we know that both things happen at the same time. You have to be licensed. You can have the direction of another qualified licensed professional, and you can try to interpret that through the rules. Athletic injury is also specifically defined in your state. It means then, and it says injury. It doesn't say injury or illness or disease. It says injury in your law. An injury sustained by a person as a result of the person's participation in an organized sport or sports-related exercise or activity. So there is a sport-related causality to an athletic injury in your State Practice Act. Other states may say things like caused by or that impact a participant's ability to participate. But your state has the as a result piece. It does expand here to a couple of different sport-related settings. Look at a few other pieces here. License is required. You can't call yourself an AT in the state of Texas if you are not licensed. Texas was a leader in doing this, and I have great admiration for the leadership your state has shown in terms of regulation of practice. You go to define who can become an athletic trainer, and you have some things about your qualifications, and you create several pathways to getting a Texas license. Now, this is probably not new to any of you, but it is unique. I shouldn't say unique, but it is uncommon nationally to see these different multiple pathways spelled out this way. One is the AT education route. You've had an education to become an athletic trainer. The other is you are a physical therapist, and you have a couple of pieces that you can complete there. Or you have a degree in corrective therapy with at least a minor in PE or health that includes a couple of pathway pieces there. So you have multiple pathways to licensure. The administrative rules add a lot of detail to spell out the specific requirements in each of these pathways, and that's what administrative rules do. They add necessary detail so you can interpret it. It is easier to change your administrative rules than to change your Practice Act. And as a result, it's typically where you see most of the richness of the descriptions are in the administrative rules. So some more fun things for you. Here's a list of what it says you do in your Practice Act. This can be performed in any setting authorized by a licensed physician. So can I work at a clinic in Texas? This tells me I can. Again, I have to do that athletic training thing, but I can do it anywhere, so that's good. Here we add athletic injury and illness. By the way, this is from the administrative rules. So we've added the phrase illness in the rules, although it doesn't appear in the Act. Other fun things in here. I liked bullet 2. This was clearly written in the athletic trainers don't diagnose era. You do an initial assessment, and you form an impression. By the way, do you know what the process of forming or doing an assessment and forming an impression is called in healthcare? The word is diagnosis. It's the appropriate word to use, although it's not specifically spelled out in your act. So you can do first aid and emergency care, you can do comprehensive rehab programs, a lot of good things. Here's what your State Practice Act says you cannot do from its language. Again, I'm not interpreting for your board. This is simply my reading of what your law says. A licensee shall not provide health care services which are not within the definition of athletic training. That was the first thing we looked at. And athletic training was, we do those things that are in the NATA description with an athlete or an athletic injury. So that's where we're there. And there is a caveat in here, though, about an exemption for Occupations Code, Chapter 157. Anybody got that one memorized? Yeah, me neither. It's a general physician of authority to delegate. So it says, and my emphasis is added here, physicians can delegate to a qualified and properly trained person, that could be you, under their supervision, which is part of your act anyway, any medical act that a reasonable and prudent physician would find within the scope of sound medical judgment to delegate. I don't think they're going to delegate ACL repair surgery to you. I do think they can delegate closing a wound. I do think they can delegate reducing a dislocation. If you have, and it says up there, qualified and properly trained, doesn't mean go make it up on your own, but absolutely within the purview of your act to delegate those things seems to exist. So, if we go back to our list, got out my red pen here and crossed out a few things. In the state of Texas, this is what I come up with for you from my list. So it says you can't, I come down to three things. Diagnose, by the way, it doesn't actually say you can't diagnose. It simply says you do an evaluation and form an impression. It doesn't say you can't use the D word, it just doesn't use the D word. The other thing that I come up with is treat non-athletes and non-sports injuries. And to me, my reading of your Practice Act looks very sports-centric. You're not alone in that. There are a number of states who have that, but most states are trying to move away from that. And they're finding a battle to do so because changing your laws and changing your patient population in your law is hard. Because other providers who perceive themselves as competing for you in the marketplace would not like you to change your patient population because you cut into what they think is their patient population, and that's a dollars and cents issue to them. But remember, scope equals education plus regulation plus competence. If I'm not competent to do something, even though it was part of my education program 25 years ago, I shouldn't do it. And that's a really important thing. But if your regulation is silent, if your regulation doesn't specifically say you can or cannot do something, then I take education out, or regulation out, and I get education and competence to determine what your scope of practice is. So that's the way that it's put together. So who's limiting our scope of practice? Why have we always been saying these athletic trainers can't thing? This is a really famous cartoon. This is from Earth Day in 1971. And it says, "We have met the enemy, and he is us." Who wrote our athletic training laws? That'd be us. Now, did we have haggling and input and lobbying and all the things you have to do in that process? Of course. But much of the things that are in a lot of our laws, particularly the first drafts of our laws, are what we put in. And in many cases, we were not very wise. Because we self-limited in many states to certain settings. Or we self-limited to certain populations. Or in my state, I'll pick on my own Practice Act for a minute. Part of the definition of athletic training in Ohio is that athletic trainers administer topical medications. That's the only route of administration we talk about in our act. So 10 years ago at our state meeting, the State Pharmacy Board gave a talk, and the chair of the State Pharmacy Board put up a slide that showed me my Practice Act and said, "You say topical medications. Therefore, it's the opinion of the Pharmacy Board in the state of Ohio that if you administer a medication by any other route, including oral, you are in violation of your State Practice Act." And we about crapped our pants. Then he said, "Fortunately for you, this is silly, and I have neither the manpower nor resources nor interest in trying to police this, but you need to fix this. You need to say that if your physician says to administer a drug, that you administer a drug. Don't limit yourself unnecessarily." And that's exactly what we have often done. But when you look at it, it's our perception of ourselves. Well, athletic trainers can't suture. Athletic trainers can't reduce dislocations. You know who the number one person saying athletic trainers can't reduce dislocations is? Athletic trainers. With no real basis in it other than we didn't teach you. Well, now we're going to teach you, and we need to get there. So we've often limited our own scope of practice and made it easy for other professions to hold us there. And then we go to try to change our acts down the road. It's pretty hard. Our perception is still limiting our scope and ability to serve our patients because it makes us vulnerable to perceived and real threats. So when the Katie was proposing some of the new content, people will pull me aside and say, the PTs will never let you do that. The PAs will never let you do that. Well, you know what? They're going to fight it, but it's awfully hard for them to say one profession can't perform something that is done by many, many different professions. It's a fight, and it's a fight that we have brought ourselves into, but that doesn't necessarily mean it shouldn't be a fight that we take on. Most medical procedures are not specifically owned by a specific profession, and almost no Practice Act in almost any state is procedure-based. They talk about your scope in very general terms, and they don't get down to the minutia of who can do dry needling or who can do injection. That's usually silent in almost every act. Education and scope evolve over time to meet changing needs for patients, and focus on core competencies and the triple aim in serving our needed patients is the mechanism by which we see that we need to evolve our scope to meet the needs of the patients already in front of us. So with that said, how do we change our scope of practice? First, we have to change the determinants of the scope of practice. The educational standards just did this. They're updated approximately every 5 years. The new set just came out. They go into effect in 2020, and they take head on a lot of these things. So here's a question for you. Next, we'll get to national certification. My question is, when the standards change, does the BOC exam change? Anybody work with the BOC on exam development? The way the BOC exam is developed is they do something called a practice analysis. In the old days, we used to call this the role delineation study, but now it's called practice analysis. They're on version 7 right now. Practice analysis looks not at education, but it looks at practice, and when it looks at practice, it says, what does the entry-level practicing AT need to be able to do? So when they design the BOC exam, they don't look at the KD standards and say what should be in the exam. They look at what is practice saying. And the KD is actually not involved in BOC exam development in any way. So they look at practitioners. So when the KD standards change, and I have, 3,000 to 5,000 students a year learning this new skill set and entering the job market, do you think those skills are going to creep into their practice? I hope so. That's why we do it. So a period of time after those students enter practice and those skills creep in, those things will start showing up in the practice analysis, and at that time they will find their way into the BOC exam. So it's not that in 2020 the exam changes. Sometime after 2020, several years, either 1 or 2 analyses after that, I would expect you to start seeing those things show up in practice to the level that they find their way onto the exam. How does state regulation change? Well, state regulation, unlike the educational standards and the BOC exam, are not necessarily revisited every 5 or so years. So state laws are updated infrequently and usually at significant effort and cost. So if your State Practice Act is overly restrictive, you have a fight on your hands to expand that. If your State Practice Act is broadly written, it makes it a lot easier in your administrative rules to do things. But it's a little hard to go back and change that. But ultimately, education leads to change in certification, and education and certification together and their impact on practice ultimately leads to change in regulation. So regulation is sort of the last of the things that happens along here. Now, we also do have some facility credentialing, although not that much in traditional AT practice, but it tends to update to keep track of modern times. So as new procedures come on board, facilities who use facility credentialing examine those when they come out. So dry needling, for example, is something that a lot of facilities have re-examined in the last 2 years about whether or not people can do them. So how do I update my own scope of practice? How do I impact what I do every day? First, figure out what your real scope of practice is. What your real scope of practice is determined by education, regulation, and competence. So what were you educated to do? What does your State Practice Act say versus not say? So athletic trainers can't reduce dislocations. It's not your Practice Act. If you are educated to do it and competent to do it, and your directing and supervising physician says, go ahead and do it, then you can do it. That's really the way that works. So first, don't fall into the myths of athletic trainers can't. Second, educate your peers. Don't let them continue saying athletic trainers can't in an uninformed way. Be informed and know where your limits are. Advocate for yourself and your profession and stand against misrepresentations of your abilities. NATA has been very proactive over the years in fighting other organizations misrepresenting what we are qualified to do. You need to be an advocate for this at your local level as well. So, don't let someone else determine your scope of practice who doesn't actually know what your scope of practice is. Update your knowledge and skills to current standards. And you're going to see a lot of continuing education opportunities available over the next couple of years to help the practicing athletic trainer get up to speed on those new things that are coming into the standards. The ECE within NATA has already put out a call for subject area experts in each of those things to start putting together continuing ed programs to do just that. I think enterprising universities are going to realize that there's a market to bring people up to the new skill set, and we'll probably create some continuing education avenues there as well. And the last thing here is be resilient. Change does not happen overnight. Look forward, see what the future for your patients' needs is going to look like, and work to advocate for putting yourself in a position to be able to meet those needs. And it's going to be a long fight and a hard fight, a fight in some cases that's resisted. But ultimately, all of these things are necessary for us to take an informed and equal footing role in the healthcare marketplace of the future. And if we don't do these things, we are really going to limit our ability to do that. And as the market changes, if we don't change along with it, then I think that doesn't bode well for where we'll be. So with that, I'd like to thank you. By the way, these are my 4 kids, 3 of them who just graduated this year, 1 from college and 2 from high school. And if you were here from last year's talk that I had to do remotely because of my flight cancellations, the 2 at the bottom here were my assistant presenters last year. So thank you very much. I'll take any questions that you have.
Great presentation, Mark. What I think is significant, though, as when, for example, what was evident when PA7 came out, is that there is a huge gap between the skill expectations that are evolving and that response and skill set for the practicing athletic trainer. I can speak in the secondary school setting. If you don't make an absolute effort to get on top of those things, you could stagnate quickly. Yes. And unfortunately, there's been, we haven't been as diligent about providing that continuing education and making those resources available to the practicing athletic trainer to stay on top of the evolution of our scope of practice. I think we need a much better effort in providing that, those educational services.
Amen, brother. I'll give you a witness. That's exactly right. We have to do a better job of that. By the way, you want people to come to your conference in the next 5 years? Suturing workshop, dislocation workshop, phlebotomy workshop. I think that those are going to be enormously attractive to providing the skills that we're going to need as we see those educational things change. Other questions? All right, well, I'm the last thing between you and lunch. Well, there's one over here. Go ahead.
There's a big difference between attending a workshop for suturing and getting checked off on that skill. You know, it's not a one-time deal. So
right.
How do you see that in the picture?
I think there's a lot of ways to approach that. If you wanted to become credentialed as a phlebotomist today, there's a number of different organizations who would do that. And they typically have a fixed amount of training that you have to go through, and the least restrictive of those says you have to have something in the neighborhood of 10 or 15 hours of training and 50 actual suturing situations on patients to be ready to do it independently. So we might see some things relative to that in AT, but again, the competence piece, which is what you're talking about, is critical. I went to a workshop, therefore I'm an expert. I don't think so. I think we do need demonstrated competence as we get there. So I don't have a great mechanism for that. I think that has to be parallel to our educational pathways, though. In the back.
Yes, sir. On what she just stated, I think I could see, since most of us do work with a lot of doctors and hospitals, that we can probably just learn the didactic here and then go practice at the hospital or the physician's office. Or
absolutely.
I mean, you know, it can be done. But I think my next question would be the credential and how it would be reflected on our licensing. You know, yes, you know, you have rules and laws, but, you know, how would the general public view us as using those skills other than being a nurse or a physician, a PA? In other words, gaining the respect and also, you know, having that occur. And furthermore, I think, too, most of us work in secondary schools, and unless you have an administration that, you know, really supports what you do in conjunction, maybe perhaps with the school nurse, you know, the healthcare administrators within the school that you could probably find your way in there and do it. It's just something
I
I've
agree
observed.
entirely. By the way, I was a secondary school athletic trainer before I went back to be an academic, and when I retired from doing the university thing, I'm going back to a high school for a few years because that's where my heart is. So I'm with you on that. I recognize that not all these skills are going to be applicable in every setting. You know, I may not necessarily be doing a lot of suturing out at my high school, for example. But we also know that jobs are mobile, and people do change settings, so our skill set has to get there. But I really like the first point that you made, which is about the credibility piece. Your credibility as a provider happens in two different places. It happens within the healthcare community, who largely don't know what you are qualified to do. And when we don't use the same language they do, that doesn't help us either. But we also have it within the public. And by the way, the public who works with an athletic trainer are usually your best advocates because they know the difference that you've made in their individual lives. So I think we have to be proactive about who we are. And I think our PR nationally has to target specific audiences in specific ways to try to help us get there. So I think we need concerted efforts on the education front, the competence front, and the promotion front. And I know that that takes time. But I can tell you this, from being the first athletic trainer ever in the room at the Global Forum on healthcare education with the National Academy of Medicine, when I got there, they said, "Why are you here?" And after one forum meeting and participating in the conversations, somebody pulled me aside in the hallway and said, "It's clear why you're here, and I wish you'd have been here 10 years ago." So we can make those inroads once people understand what we do and what we know. So with that said, I think I'm about out of time, so I will get off of here, and I think we have some giveaway folks, and then they'll get with you for the next of the program. But I'm going to be here all day and at lunch. If you have questions or want to just chat with me, pull me aside. I'd be happy to talk. Thank you.
Thank you, Dr. Merrick. Okay, right before lunch, we're going to have some door prizes.